Hi, today we are gonna learn how to diagnose a patient with acute appendicitis and how we approach to it. Imagine that you work as a GP in emergency room and an 80-year-old girl comes with abdominal pain. In the first step, which is taking history, we try to define the patient's pain by Socrates. The pain site has been preumbilical first and migrated to right lower quadrant. Started suddenly from 6 hours ago. It's dull in character, radiates nowhere. Vomiting, anorexia, and nausea have been started a few hours later. Increased by time and became constant. Exacerbates by movements like walking. And she gave the score of 7 of 10 to her pain. Now let's take a look at appendicitis symptoms before going for physical examination. Classic symptoms are right lower quadrant pain, anorexia, nausea, and vomiting. But there are also several atypical or non-specific symptoms including diarrhea, constipation, indigestion, bowel irregularity, and flatulence. We see that most of our patient symptoms are consistent with this, but still too early to make a decision. On physical exam, we check Miss Brown's vital sign. The only significant point is a low-grade fever. On abdominal exam, we note right lower quadrant tenderness. Rectal and genital exams seem normal. Now let's talk about appendicitis signs. The patient seems unwell and may be flushed at first and then become pale. Low-grade fevers reaching 38.3 centigrade may be present, and higher grades occur as the inflammation progresses. Another sign is right lower quadrant tenderness, usually at McBurney's point. If we draw a line from anterior superior iliac spine to umbilicus, this point will be 1.5 to 2 inches from ACs. Local rigidity and rebound tenderness may also exist. As you know, rebound tenderness is a pain upon removal of pressure rather than application of the pressure to the abdomen. The next sign, Robson sign, refers to a pain in right lower quadrant while palpating of the left lower quadrant. The next two signs are related to anatomic variations of the tip of the appendix. Swas sign is associated with retrocecal appendix manifested by a right lower quadrant pain with passive right hip extension, and low end tenderness may be seen. Obturator sign is associated with pelvic appendix, which is based on the principle that the inflamed appendix may lie against the right obturator internus muscle when we flex the patient's right hip and knee, followed by rotation of the right hip. Because of the low sensitivity, which is about 8%, this procedure is no longer performed by clinicians. Let's go back to Miss Brown. We had a patient with a dull right lower quadrant pain starting suddenly from 6 hours ago, radiating nowhere, associated with nausea, vomiting, and anorexia. The pain increased by time and became constant, exacerbates by walking, and she prefers to be immobile. She gives a score of 7 of 10 to her pain. She was febrile on the examination with a right lower quadrant tenderness. Note that we obtain these information in a few minutes. From the first second that we see the patient, differential diagnosis across our mind. Here we see different conditions that can cause a pain in the right lower quadrant and lower parts of the abdomen. We keep them in our mind and try to find Miss Brown's most possible problem. Based on our history and physical examination, we may have different priorities for them, and even narrow or widen them according to the laboratory tests and imagings. Don't forget that being accurate and flexible leads to the right diagnosis. In female patients, like our case, gynecologic and obstetrical conditions can be included, like ectopic pregnancy. So, beta-HCG is usually checked in females of reproductive age. Let's take a quick skim of the others. Pelvic inflammatory disease causes a pain that worsens during coitus or menses with endocervical discharge. Ruptured ovarian cyst causes sudden abdominal pain that begins during extraneous activity and may be accompanied by light vaginal bleeding. Colon sign may be also seen. Tubo-ovarian abscess associated with fever, chills, and vaginal bleeding. Vaginal discharge. Ovarian and fallopian torsion causes a sudden abdominal pain with waves of nausea and vomiting. Endometriosis causes a pelvic pain more severe during menses, deep dyspareunia, dysmenorrhea, abnormal menstrual bleeding, and infertility. Mittelschmerz causes mid-cyclic pains. CT scan, ultrasonography, and exact gynecologic and obstetrical history can help us to differentiate them from appendicitis. Acute diverticulitis. CT scan with oral or intravenous contrast can help in patients suspected of having acute diverticulitis. Meckel's diverticulitis. If an inflamed appendix is not found on abdominal exploration, the surgeon should search for an inflamed Meckel's diverticulitis. Acute ileitis, most commonly due to Yersinia, Campylobacter, and Salmonella, should be considered in the case of acute diarrhea, which our patient didn't have, so it seems unlikely for Miss Brown. Now, urologic conditions like renal colic associated with the pain that waxes and wanes in severity and develops in paroxysms or waves that are related to the movement of the stone in the ureter and urethral spasm. CT scan, ultrasonography, and abdominal X-ray can help us if you are suspected. The patient is rising in agony and usually requires parenteral analgesics, so we cross this one out. Testicular torsion and epididymitis can also be included in a male patient and can be further examined on testicular examination. Perforated appendix is also a differential diagnosis. Once inflammation and necrosis occur, the appendix is at risk for perforation, which leads to a localized abscess formation or diffuse peritonitis. Perforated appendix must be considered in a patient whose temperature exceeds 39.4 centigrade, whose white blood cell count is greater than 15,000 cells per microliter, and whose imaging studies reveal a fluid collection in right lower quadrant. Now, mostly suspicious to acute appendicitis, we get Miss Brown's Alvarado score. Right lower quadrant pain, 1 score. Right lower quadrant tenderness, 2 scores. Anorexia, 1 score. Nausea or vomiting, 1 score. Fever, 1 score. Rebound tenderness, also 1 score. And leukocytosis, 2 scores. For Miss Brown, that would be a total of 6 scores. Scores lower than 4 are unlikely to have appendicitis and will be evaluated for other diagnoses. But 4 and higher scores need surgical evaluation and imaging. Do not forget that experienced clinicians may use clinical judgment in the place of Alvarado score. In the first part, we talked about signs and symptoms of the appendicitis. And in the next part, we will learn how to manage our patient who was Miss Brown. If you liked our video, so like it please and comment your questions. At last, if you would like to see more videos on diagnosis and management of diseases, subscribe to our page.